Hi everybody. Uh, my topic today is automated periodontal probing and charting. Definition. Technology offers standardized probing, which is computer-assisted direct data, pressure-sensitive and voice-activated probes are option to manual probing, which measures gingival attachment level using occlusal or incisal surface as fixed landmark and which transfer data directly to computer. It requires computerization of dental operatory and can be used by periodontics and academic institutions for research. In addition to probing depth, most computerized systems store and reveal information on the attachment level, recession, mobility, and furcation involvement in an attempt to overcome some of technical challenge associated with manual probe. What the difference between manual and digital perio probe? The manual probe are considered first and second generation probes, and generally dental hygienists will need a second person to write down the information. Different practitioners probe at different angle and pressure, creating possibility of differing or conflicting probing depth. It is not pressure sensitive. When we compare to the automated system, it is third generation probe were developed to prevent such discrepancies. Examples of these probes and their related system: Florida probe, Go probe, probe 1, dental R80. The first or prototype probe is Foster-Miller probe. The main mechanism of action is by detection of cemento-enamel junction. I will talk briefly about each type of probe, and you can look at the photos and you can learn more about this system. So the ball of this probe is moved or glide over the root surface at controlled speed and record the cemento enamel junction. This photos shows the Foster-Miller probe, which is a prototype automated probe system. The other one, Florida probe, this is most widely used, and work with handpiece with diameter 0.45 micron and sleeve has diameter 0.97. There is constant pressure 15 gram is provided by coil spring inside the handpiece. This photos shows like how a Florida probe system work and what the component. The other type is Toronto automated probe. This probe in this probe, the sulcus is probed with 0.5 millimeter nickel titanium wire that is extended under air pressure. The advantage of this is incorporated electronic guidance system to improve precision in probe angulation and estimate the biophysiological integrity of dentogingival junction by measuring intra-pocket probing velocity. There is also perio-temp probe. This enables calculation of temperature differential between probed pocket and subgingival temperature. Higher temperature pockets are signals with red emitting diodes, so this means there is inflammation. The last type is interprobe or periodontal probe. This is exactly the same Florida probe. This is pictures of periodontal probe. So what the advantages of this system? It is audio-visual reproduction of exams result, which allow us to see wider and more complete view of patient mouth. It allow us to better explain to the patient when there is issue or by allowing them to visualize it. The results are transmitted automatically to the patient without need for intermediate procedure that saving time, provide us with a clinical history of patient which allow us to easily see both graphical and numerical change over time. The results are always accurate, reproducible, and are not dependent on factors such as change of the doctor or pressure applied. Standardized probing force typically 15 gram improving accuracy. To also use in the research, the flexibility and cylinder design compared to the rigid tip of standard handheld probe is better suited to reach the base of the pocket. It is more occupied to follow the curvature of the root. At the same time, there are several disadvantages for this system. Tactile sensitivity is decreased. They don't resolve the problem of other anatomic factors that affect proper insertion and penetration of perioprobe. Thus, the accuracy and reproducibility is affected. Probes may pass beyond the junctional epithelium in inflamed size, overestimating the pocket depth. After the inflammation has resolved, probe may not penetrate beyond the junctional epithelium, lead to underestimating of pocket depth. This technique also do not provide three-dimensional information about the disease. And the last disadvantage, it requires declination experience to develop the necessary skills to effectively use the system, and it's expensive. In conclusion, new developments in the field of perioprobe provide potential for error-free determination of pocket depth and clinical attachment level at a very early stage with certain restriction when detecting pocket depth higher than 7 mm. The limitation of design of electronic probe do not permit complete replacement of standard manual probe. So this photo shows how automated system work and how it look like. And I have a link to this video. Like if you like, watch it in your free time. Thank you.